Well, I was asked to give a discussion on ordering images for people who don't really see a lot of people with EDS, or some idea of what radiology studies might be useful and helpful, and some of the findings we might see with them. And the imaging evaluation of the cervical spine, of the lumbar spine, can really be started with an MRI of cervical spine, an upright study with flexion, extension, and neutral projections, computed axial tomography of the cervical spine with rotation and flexion, and an MRI of lumbar spine. Really don't need my imaging to make a diagnosis of hypermobility. The upright MRI is useful to localize segments of instability, impingement, areas of motion, and to define other problems that may be going on. I'm really here to confirm clinical diagnoses and exclude other causes that might not have been obvious from the start. Other causes or other issues that are sometimes seen are things like tumors, someone suggested I put in a sample prescription, so my son helped me with this one. CT of cervical spine with flexion, rotation 90 degrees to right, 90 degrees to left. The indication is Ehlers-Danlos syndrome, pain and instability. And for the cervical spine MRI, upright with flexion, extension, and neutral, and evaluation for instability, head pain. An upright MRI, I actually don't have one, but the advantages of it are that it's somewhat dynamic. The positions can change. The study can be imaged in different positions. When someone's sitting upright or standing, there's actually loading. The discs and the tissues actually move in position or deform with weight rather than laying down. But the disadvantage of this type of imager is longer imaging times. Because we're sitting up longer, there's more motion. They're lower field strength units, so it generates less signal. What that all in all means is there's less for the computer to work with, so the pictures are grainy. And the great advantage of MRI is soft tissue contrast. If there's a shortage of signal, there'll just be less soft tissue contrast. They're done in an upright position, in neutral, which is upright, flexion, which is bending forward, and extension, which is tipping back. And if there's instability, we're looking for the level, the amount of movement, sometimes forward or back, angular change, and if there's compression upon the spinal cord or nerves. This is a 38-year-old who had decompensation 3 or 4 years ago and is really homebound at this point. This is a neutral MR, and the only thing, really, there's a small disc, but it really isn't very impressive on this neutral position. This is an upright image. But when we go to flexion and extension, she has 24 degrees angular motion at C5 and C6. 11 degrees is really the most that somebody should have, and 13 degrees is probably going to benefit from stabilization if that's a symptomatic level. Some people may have more motion, but if they're not symptomatic for that level, I'm not sure what it means, because I'm imaging a series of problems, but the images don't always tell exactly what's going on for the patient. That's the physical examination and history. We look at the craniocervical junction, a clival axial angle, Grab-Oaks measurements, and vertical Harris and horizontal Harris. Clival axial angle is well, let me go through what's here. This is the back of the head, lower part of the brain, and top of the neck. This person has a number of problems, but this is the cerebellum, This is the pons. It's a part of the lower brain. This is the medulla, and it's stretched down to lower C2. Normally, the medulla finishes here, above the base of the skull or foramen magnum. This person has, this is the clivus, this is the odontoid, or the first part of the cervical spine, and we're looking at the angulation, or how the bones articulate. And the implication is that the brainstem is draped across the odontoid, or a piece of the clivus and the odontoid. The thought is, or the understanding is, that when neural tissue is dragged across, when there's stress across it, the nerves just don't work. And repeat stress, repeat injuries result in long-term neural death and dysfunction. Normal range for clival axial angle should be 150 to 170 degrees. That means that the brainstem and the nerves can pass through without touching the bones. If it's in a neutral position and already on the bone, when someone moves their head, there's even more trouble. So this, while it shows a problem, it doesn't even, it's not the full magnitude of the difficulty that this person may be having. Grab Oak's measurement is from the bottom of the skull base, we call it the basion, that's the front part of a ring where the neural tissue comes through, to the bottom of C2, and we draw perpendicular to the end of the soft tissue. It's a rough estimator of how much the brainstem is being squashed, or potential for having impingement by bone, or by bone and soft tissue. Normal is less than 7 millimeters. 9 is definitely a place for big trouble. If someone's symptomatic, this is too much. And there's the issue with Chiari malformation that this person has. I figured I'd put it in because she has it. There's 7 millimeters below the foramen magnum. Normal can be 4 to 5 millimeters below if there's no impingement. But when there's impingement, that can be pathologic. This is at 7 millimeters. There's no real discussion that that's a problem. Vertical Harris measurement correlates to the position of skull base to the tip of the odontoid. Part of the question or problems with this is the skull base deforming to allow the neck to move, or the cervical spine to move further up into the lower part of the brain? This is a way of looking at a secondary problem. If the tip of the odontoid is up too high, that means the skull base has moved up, or the cervical spine has moved up into the skull base. This angle was developed really for trauma because it's something that can be seen on x-rays on a lateral projection, and if it's more than 1.5 centimeters, there's got to be a big ligamentous injury across from any normal variant. Horizontal Harris measurement is what the distance between the back of the base of skull, foramen magnum, and a line drawn perpendicular to C2. That's also an indication of how much space is available. In this person, it's the same issue. She's got a small posterior fossa, which results in the posterior part of the brain, the brainstem and the cerebellum, being compressed and pushed through the skull base, pushed through the foramen magnum. CT of cervical spine, we often do it in flexion and maximum rotation to the right and or the left. This is really an indirect indicator of atlantoaxial instability. That's the first and second vertebrae where there's rotation. And that's more than 50% of our ability to turn our heads to the right and the left. If the ligaments loosen there, there's possibility for impingement. So this is someone laying on a CT table with their head turned as far to the right as possible. And this is a sideways view or reconstruction of that. And these are 3 images. This is the skull base, a little bit above the foramen magnum. This is C1, this is a complete ring. And this is C2, at which point I would measure from most likely. This is the odontoid. It arises from here. And this is measurements that I would be doing in an axis perpendicular to the, or anterior posterior dimension for the vertebral body. I'm measuring about 80 degrees, and this at a perpendicular is about 40 degrees, 42 degrees. And much of the time it's a complex position as opposed to simply being turned. People tend to move a little to the right, a little bit forward, or a little bit back. So there's some estimation about this. But this is an approximation for a recognized clinical problem. And the question of hypermobility relates to instability. This is C2 and the odontoid. This is the sides of C1. That's this piece here that we're looking at. And between C1 at 48 degrees and C2 on this projection, 5 degrees, that leaves 43 degrees rotation. Normal is said to be 37 degrees. Punjabi and White suggests there can be vascular compromise above 37 degrees. Probably 40 to 41 is pathologic. Anything more than that, we're accepting that there's ligamentous instability. And the reason it can turn that much is there are ligaments that hold our neck together, and there's muscles that help stabilize it. In Ehlers-Danlos syndrome, those ligaments are not functioning properly, they're lax, and they allow this degree of rotation. This is a 3-dimensional reconstruction, and it's not as, this is the skull base, this is the ring of C1, this is C2 with the odontoid hiding behind part of it. And this person is turned, and this is the amount of the articular facet. Normally, the bones are in contact. This, it's almost completely off. Just implies that there's a lot of rotation. Here's a reconstructed image from a flexion view. And it's remeasuring a Grab-Oaks measurement, showing that there's both bone from this odontoid and soft tissue touching the lower part of the medulla or upper spinal cord. And this is in essentially a neutral position. There could have been more motion to generate more impingement. This young lady came to the emergency room with numbness in her hands, weakness in her hands and legs. And the main problem was that she was bothered by upper extremity symptoms. These are reconstructed images from a CT, and this is an MRI done the next day, and there's not really very much to see here. But she had an MRI of the lumbar spine, and she had a fatty lesion, lipoma, a lesion of fat, which is attached all the way to the cord. So normally, the end of the spinal cord, we call it a conus medullaris, ends between T12 and upper L2. Well, hers is at the L4, L5 level, so it's pulled down this far, at least 2.5 segments, and it's under tension. This is more often what we end up seeing. There's a little line of fat, and it's attached to a defect in the lower sacrum. This is the bottom part of the spine. And it yields a tethered cord, also tension. Even though the spinal cord here ends at the L2-3 level or L2 level, this is still abnormal. We are taking, when we see a fatty phylum, that suggests there's abnormality with the connective tissue and the cord is under tension. Most of the people with EDS that we see, even though they have a tethered cord, symptoms of a tethered cord, there's no imaging correlate for that. These are being done to make sure that we don't have a fatty phylum or a tumor, the lipoma. There's little problems that we're recognizing. This person had a decompression without stabilization and continued to have a syrinx and was continuing to have headaches and visual issues. The clival axial angle was never fully corrected due to the lack of stabilization. Here's another fellow with the same problem. He comes 6 years ago with tonsillar ectopia. This is way low. This is a Chiari malformation. This is his spinal cord with a large syrinx. The fluid within the cord is a syrinx. He had decompression. Oh, this is same business. He ended up having decompression, but the syrinx hasn't really gone away. There's still an element of impingement, and he's got worsening quadriparesis. He wasn't really interested in having surgery at this point, but had still come around asking for an opinion. This is someone who has both Ehlers-Danlos syndrome and an inflammatory arthritis and was having issues with headache, nausea, vomiting to the point where they were losing weight, and hypertension, which really wasn't well controlled. And there's brainstem impingement, even though the tonsils are in the correct position. This is an MRI, and it doesn't look near as scary on the MRI as it did on the CT at that level. One of the issues with MRI is there's more room for artifacts. That doesn't project it. There's definitely more impingement than this shows. This is the spinal fluid. This is the cord. There's no space. The brainstem is deformed. Inflection and extension. There's no big segmental instability. And presented with worsening leg pain and urinary retention. The MRI of the lumbar spine is normal. One of the things that we may notice in patients with Ehlers-Danlos syndrome and facial pain is dislocation of the disc, let alone dislocation of the jaws. The disc is held in with connective tissue. This is to localize. This is the jaw. This is the skull base. Does this project that there's a little black bow tie? Here it's pulled forward. Here on the opposite side, it's between the condyle, the back part of the jaw, and the skull base. This is one of the things that people with Ehlers-Danlos are more prone to. Again, a patient with instability, rotation at C1 and C2, a difference of 40 degrees, which is abnormal. Another thing to look for is going to be the movement between the different levels. This one is sliding forward at this level, which is C3, C4, C5, and lesser C6. More than 3 millimeters is abnormal at either moving forward or back, and it suggests there's instability. Just that on some of the MRIs, is the contrast reasonable there? These are 2 images from this person's MRI of brain with contrast. Normally, this should be filled with bright signal because it would be venous blood. Instead, there's blood clot. This person has jugular venous thrombosis. This is the right jugular vein. This is the left jugular vein, but it didn't opacify. This is at skull base, so we're just above the foramen magnum. This is the jugular vein, and this is the jugular foramen with no opacification. There's thrombus. We also do radiography in that the open MRs take 4 or 5 minutes per sequence. Some patients can't hold still that long. They're able to push or bend further in the radiography suite for a few seconds than they would be holding for 5 minutes. And this is someone with hypermobility, although they don't bend forward all that far. There's quite a bit of bending back. This person didn't have any instability to move forward or back, and although a lot of the levels have a lot of angular movement, there'd been no there's no localization, and this really wasn't a surgical case. We tilt to the far right and to the far left. Again, tilting forward and back. There's angular motion at the level beyond the construct, which was the C5, C6. This is somebody post-op who wasn't stabilized, and again had abnormal clival-axial angle with impingement. Again, showing someone else. Can you actually see the structures here? From my angle, I can't. But it's a Grab-Oakes measurement of 1.1 centimeters, clival-axial angle of 124 degrees. That's an abnormality. It's too much. And on the extension or tipping the head back, it goes from 124 degrees to 149 degrees. This is normal range. In extension or tipping back, there's impingement. And my final case is a 92-year-old who presented to the emergency room with a fall out of her chair onto her bottom and developed quadriparesis. Well, this is soft tissue surrounding this spinal cord. At C1, C2, we call it pannus. It means thickened tissue. And at this level, there's no space for the spinal cord. The soft tissue is pushing on the cord. And if she were a surgical candidate, decompressing or allowing more space there would help her. Another person. This person came to me with quadriparesis, increasing deep tendon reflexes, weakness, and she's got 130 degrees. There's reversal of cervical lordosis. I question that the cord is draped or pushed against the back part of the front part of the spine. This is what she looked like 2 years earlier, and she looked 4 years earlier. And it really hasn't changed all that much, although she's becoming more symptomatic. I question that she may have a tethered cord in addition to having skull base craniocervical junction problems. And one of my frustrations is seeing this sort of thing and recognizing that it's a problem. But the two earlier studies were both read as normal. And thank you.